Morning, everyone. Before we start, I'd just like to know who you are and what you do if you work, and particularly if you're interested in any one issue, then I'll try to cover that. So can you just tell me?
My name is Pam Jones. I've been a CASA about 2.5 years. I'm a homemaker. I have a 14-year-old son, and one of the issues I'm dealing with my current CASA mom is borderline personality.
Okay.
Hi, my name is Mickey Jones, and I work, my real job is with Time Warner Cable. I've been a CASA for a little over a year, but haven't been very active lately. I'm just getting back into it, so I'm just here to learn everything.
Any particular interests that you have?
Probably the reactive attachment
Disorder. Well, so far I've got both of those, covered both of those. Okay.
Hi, I'm Adrienne Austin. I've been a CASA a little over a year, and I actually work in the finance industry, so I'm just here to learn more about the presentation.
Okay.
My name is Fred Sweden. I'm a foreign service officer. I have been with CASA since May, and I'm interested in my case is been diagnosed with bipolar 2, narcissistic tendencies. Interested.
My name is Tacita Westerhouse. I've been at CASA since January of this year, and I work in market research, and I'm interested. In my case, the mother has been diagnosed with depression and anxiety, and I'm wondering how it parlays into her inability to care for her children.
Okay.
I'm Shirley Finkelstein. I'm a retired person. Been with CASA for almost 2 years. And I'm interested really in everything that you say, but I guess particularly attachment disorder.
I'm Mary Grant, and I work for a device manufacturer. I handle a lot of their marketing and organizational reorganization. And I've been CASA almost 5 years, and one of the things that I'm interested in is I've got a 15-year-old girl with a lot of anger issues that she can't deal with.
My name is Peggy Peters, and I'm retired and just arrested in police.
Karen Luckner, I've been a CASA less than a year, and I work as a commercial insurance agent, and I'm interested in learning about schizophrenia.
My name is Karen Butler. I've been at CASA for about 8 months. I have 4 girls on my case, and it's a case dealing with sexual abuse. So I'm not interested in anything in particular, but
I've been in CASA for 2.5 years, and I'm interested in mental health issues. My current case, the mom has schizophrenia, and everything else just about. It's pretty bad. One of my questions has been with this case and the case I had before. What kind of things are part of the illness, and what part of the thing, of the way mom acts or dad acts is just the way they are, personality? It's kind of hard to differentiate, what's going on there.
My name's John Dillon. I do some financial management consulting. I've been in CASA for about a year. My current case, the mother and a couple of the fathers have mental health issues, and I'm interested to see through therapy what type of progress parents can make in becoming more complete functioning adults.
Hello, my name is Phyllis Rayner-Surratt. I've been a CASA since 2004. I just have a general interest in the topic, and I work for a government contractor.
Hi, my name is Dan Bocello. I'm retired from the federal government, been at CASA for about 2 years. And the mother in our case, I guess allowed the children just to kind of do things that cause themselves harm. And just was very passive about the interrelationship.
Hi, I'm Pat Cachado. I'm the project manager for FedEx. I've been out of CASA for like 6 or 7 years now. I think I started in Pittsburgh, and when I moved down here, I continued with CASA down here. I'm on my 4th case, and every one of them has a different mental health impact. So generally speaking, we just generally want to hear about it. Right now, I guess I'm more interested in reactive attachment disorder.
My name is Tessa Tuso. I've been at CASA since January of this year. Just general interest in the subject.
Tammy Holt. I'm new to this CASA program, but I was a CASA before. My background is in criminal justice and justice services. The case I currently have, the 2-year-old's been identified with some type of attachment disorder, so, but I love mental health, so.
My name is Catherine Hyman. I've been with CASA for almost 3 years now. I have a general interest, but I am curious why my teenage boy, every time he gets an evaluation, it's a different diagnosis. You could say anything to that.
Hello, I'm Teresa Hayden. I have my first case. I've only been with for 5 months. And the mother is diagnosis depressed. She's just turned 19. The little child has just turned 5. And she was abandoned by her mother when she was 5. So I think they're playing out some of that. Saying she's reliving that with her little boy. But again, with her and with the little boy, he shows a lot of anger. The main first thing he'll do is kind of act out and quickly he'll calm down. And I don't know if that's just his behavior. He's identified as special needs, but someone will try to deal with him and or with his mother.
Good morning. My name is Deepak Kapoor, and I graduated with Cerise and And my children's mom, she had 2 independent assessments on one as a schizophrenia challenge that she's facing, the other was bipolar with manic episodes. So I'd like to understand that.
My name is Tony Cooper. I've been a CASA for about 1.5 years now. By trade, I'm a molecular biologist and geneticist. With my case, I just have a general interest, but I have a 14-year-old depressed child who went through some suicidal episodes. So I don't know how you sort of moody teenagers with real depression. I mean, he seems to have wide swings. He's very almost manic at times, and he's super hyper. So I don't know. He hasn't been diagnosed with bipolar, but it seems like he might have some indication of that. So I'm curious about that.
My name is Mark Knopf. I'm interested due to the fact that I'm a CASA for about 1.5 years now, and interested in the fact that both the mother and father in my case were court ordered to have psychological evaluations. Just wondering why the court would do something like that and what the court would glean from it and what the whole process overall is involved.
I'm Nancy Dolliver. I'm a political satire performer. I've been a CASA for about 1.5 years. I'm interested in when you have a parent and a child that are maybe going to be reunited and they both have mental issues, how do they each help manage what's going on with others? And also I have a depressed teenager, and how do you interact with them on a regular basis without getting drawn into their depression?
My name's John Rumley. I've been a CASA since January, and I have a general interest. And also, like Mark, I want to hopefully find out a little bit more on the process of a diagnosis.
I'm Siobhan DeCourcy. I've been a CASA for several years, and I just have a general interest.
Hi, Marianne Wilford. I'm a volunteer supervisor. Strong general interest, but very curious about sexual reactive disorder, as we talked about.
I'm Linda Williams. I'm the executive director of CASA. Thank you, Dr. Lindahl, for being here. We're so grateful. I think that's obvious. And grateful to all of you for taking this Saturday to learn more about this critically important topic for CASA.
Hi, my name is Virginia Cole, and that's like a hole in the ground, HOA. And I've been a CASA for going about 4 years. I'm working on my 3rd case, and anytime I have an opportunity to learn something, I want to be here to learn it.
Hi, I'm Rebecca Arnold. I'm a volunteer supervisor with CASA for about 1 year now, and before that I was a CASA for 2 years. And most of you know from my master's, I have a very strong interest in anything dealing with psychopathology.
Okay, and then we have a couple people that just introduce yourself, tell us what you're interested in.
I'm Nancy Webster. I've been a CASA volunteer for 2 years, and I'm, like some of the others said, I'm just interested in anything new that I can learn that I didn't know before.
Okay.
My name is Josephine Rivera. I'm a counselor for almost a year now. I have a 3-year-old. I'm interested in learning how you can help a little one when they suffer from trauma, but they can't say what's wrong with them.
Okay. Okay, I guess that's everyone. Welcome, everyone. I think my harshest critic will be in the back here. Rebecca is a graduate of our program, and she's had this course for a semester, 45 hours of training and homework and papers. So I'm going to try to boil this down for you so you can understand a little bit better some of these reports. I read some of these reports that Lisa gave to me last week, and they are very complicated, so I'm sure that it's hard for you to understand. Some of them were even a little hard for me to understand. So I want to tell you how I'm going to do it. I gave you a handout. This is what I'm going to talk about today. This is going to be on the screen. You can take notes on the side of it. And then I gave you a handout, this classification, global assessment of functioning, and then this handout here. And then a short article. So those should be in order of what I'm going to talk about. I think for most of you, I've covered in here the diagnoses that you're talking about. I can't do a lot on treatment because I just don't have time, but I can answer some of your questions. And I don't have a lot about sexual abuse because that's a whole different issue, but I'll be glad to talk a little bit about it, answer questions. So I hope you'll interrupt me anytime, ask me questions, and particularly when we do a diagnosis, if you have a client or a parent, child that has this diagnosis, I'd be really interested to hear a little bit about your case. Okay, before we start, this is our Bible, which I don't know if you guys have seen this. DSM-4, TR is the text revision. So this not only has the diagnosis, but it has a lot of interesting information about prevalence and causes and so forth. I'm donating this to CASA, so it will be in the office, and you guys can read it anytime you want. Everything in this lecture is key to this book. All your handouts are from here. So what I want you to be able to do at the end is to go and look up the diagnosis that you have, and you'll be able to learn something about it. Okay, and then after an hour or so, we'll take a 10-minute break, and then later we'll take a bathroom break too, so you'll have plenty of break time. Okay, I first just want to tell you what psychopathology is, long word, which basically means the study and development and origin of mental disorders, or the manifestation of that. So if you say, I want to study the psychopathology of this issue, that's what this means. Okay. Now just to clarify, abnormal psychology and clinical psychology are somewhat the same thing. Abnormal psychology is the academic study, and clinical is what we do. Clinical is we deal with the actual patients. Okay. This is the DSM-4. 1994 is the edition that just has the diagnoses in it. This particular one is 2000. Same diagnoses in it. So if you get the DSM-4 older one, which is red, same diagnoses, you can use that one also. People often ask where this came from. I think that people take it too seriously sometimes. Someone said they had multiple diagnoses from multiple evaluations. I'm going to talk a little bit about why that is. In 1952, the government wanted to gather some statistics on mental illness, and that's where this started. But basically, what it's for is to facilitate our communication with each other, right? So if you are dealing with a CASA case and you have a diagnosis, hopefully you'll have the same thing in mind that the person who wrote the evaluation has. So you can communicate that way. Also, it's good for research in terms of at least you have some definite criteria that you can use to decide whether somebody has something or to study the disorder or the causes. Now, what you'll see in this book that this is a description only. So it has very specific criteria for a diagnosis. And there'll be a lot of people who won't fall into that, although you kind of intuitively know they're depressed, for example. You have to have it for a certain amount of time. You have to have certain numbers of these criteria to officially make the diagnosis. Now, in practice, we don't always do that. Sometimes for forensic issues, like CASA cases, we'll be more careful, but we don't always stick to this. You can see how it was done. 150 literature reviews, 50 data reanalyses, so they took existing data and studies and reanalyzed it, and then 12 field trials where they looked over the material to see if it worked. However, it is not something that we memorize, and if you see an expert witness in court just going down these diagnostic categories, they've memorized it before court because it's very specific and hard to remember sometimes. They then had 13 working groups that looked at the diagnoses, and this is consensus-based, which means it's voted on. So it's not as official, kind of scientific as you think. It is based on research and what we know, but there's a lot of political issues in this. For example, homosexuality used to be a diagnostic category. Now it's not. I think you can figure out why, because the culture has changed in the way homosexuality is viewed. We also used to have categories like masochistic personality disorder, which were applied to battered women. And you can see how women's groups managed to get that classification out. In the back of the book, there are a lot of possible categorizations for the DSM-5 revision that you can look at. And you will see that when we go through that some diagnostic categories that you think should be there are not there yet. Postpartum depression isn't really covered very well, for example. Okay. The limitations are the categories don't have discrete boundaries. Lots of times they're overlapping categories or criteria for the diagnoses, and some people don't fit into any of them, as I think you'll see from your cases. There are also ethnic and cultural considerations. They've tried to put this in the book, but I think in practice, you people who see many different ethnic groups know that there are a lot of problems with evaluations of people who are from different ethnic groups or cultures. One example I can give you, Lisa gave me some reports to read, and I don't know if anyone has this case in here, a woman from Africa who said in her history that all of her children had been executed in front of her. So you would kind of think post-traumatic stress. And she came over here and she has I think her daughter is 2. Her daughter was sucking her thumb, and she bound her thumbs to the point where her thumbs had to be amputated. So she had the evaluation, and this whole traumatic history was in there. She didn't speak English. So they did a nonverbal test of intelligence, and it came out in the retarded range, 63, which is in the definitely retarded range. And then there's her culture. So how do you separate those things out? Why did she do this? It's a very bizarre kind of thing to do. Is it ignorance? Is she mentally retarded? Is this something in her culture? It's very unclear, and I think the report was unclear for that reason. So you have to take those things into account. Sometimes you just don't know the answer. Okay, so the definition. It does not mean that there's no biological component, because there is to most illnesses, we feel. So because it says mental disorders, doesn't mean that there is no biological component. The symptoms have to be clinically significant. They have to bother the person. They have to be a problem, with the exception of personality disorders that we'll talk about that bother other people, but not the person who has them. There have to be some risks with them, and they can't be totally cultural diagnoses. Plus, it has to apply to you can't diagnose a group and then put every individual in that category. Okay. So stop me if you have any questions along the way also. Okay, this is the multi-axial assessment that you see at the end of most of these reports. I'm going to explain to you how they work. Axis 1 are clinical disorders. That is pretty much everything you can think of: schizophrenia, depression, post-traumatic stress, and so forth. Most of the diagnoses that you are familiar with. Axis 2 is personality disorders and mental retardation. Does anyone see like what those two might have in common, that they would be on the same axis? Can you think why personality disorders would be on that axis rather than one? Well, the reason is they're considered untreatable, really. It seems to be changing somewhat in the field. People are trying to treat personality disorders, but it's always been considered something that you just really can't do much about. Same as mental retardation. So that's why it's on axis 2. Axis 3 are any medical problems that you have. Axis 4 are the psychosocial stressors, and axis 5 is a global assessment of functioning. I'm going to show you each of those. Okay. This is axis 4, and you will see that the evaluator will usually pick one of these problems. These are the stressors on the person: primary support group, occupational problems, economic. Child abuse is another one that you can put on there. So these are the stressors that the person is dealing with. Okay. Axis 5, I have on your handout right here, if you can find that. This is the scale. It should be right there with your things. Now this is actually fairly subjective, and you'll see that in the evaluation, the evaluator will pick a number. So they'll say GAF colon 50. So you look on here, 50 serious symptoms, suicidal ideation, severe obsessional rituals, or any serious impairment in social, occupational, or school functioning. So what the person who's doing the assessment does is look at this chart and try to get a rough idea of where the person is. That is somewhat helpful if you look at it quickly to kind of see where the person is functioning. Okay, I'm going to look, this is a recent CASA case. This is an evaluation that Lisa gave me to look at just to show you what it looks like. This is a 21-year-old unmarried woman whose 2-month-old was removed for basically medical neglect. Axis 1, these numbers, all of the diagnoses are numbered, so you'll always see a number by it, 314.00. Attention deficit hyperactivity disorder. Axis 2 is adjustment disorder with anxiety. That's actually not right, that should be on axis 1. Axis 2, personality disorder, NOS, which means not otherwise specified. That's there if the person doesn't meet any of the criteria, enough of the criteria to be diagnosed. With paranoid, borderline, and narcissistic traits. And I'm sure a lot of the people that you see have this diagnosis, right? Axis 3 is a pituitary tumor. Axis 4, you can see the stressors. And axis 5 is a GAF of 40, which is really very low, right? So this person is in trouble. A lot of different diagnoses. When you have a lot of diagnoses like this, it usually means that the evaluator really can't tell what's going on with the person. It's too many diagnoses. ADHD and adjustment disorder and a personality disorder, right? A lot of them are overlapping, as we'll see. Okay, these are the diagnoses I'm going to look at today, and if you want another one, you can ask me as we go along. Pervasive developmental disorder, ADD, reactive attachment disorder, several people have. Substance-related, schizophrenia, I think some people have a parent with that. Mood disorders, anxiety, adjustment disorders. And out of the personality disorders, I'm going to do the borderline, since we have so many of those, I think, in this caseload. Yes?
I just have a question about some you covered on a different slide. Mm-hmm. It's axis 2 personality disorders and mental retardation. You say that they're not treatable, but yet it seems that they still give a lot of medication to people who can fall into this category.
Yes, when the DSM first was developed, they were considered not treatable. Now, they're certainly extremely resistant to treatment, but people are trying to treat them today. And you'll see books on treatment of different personality disorders. The medication is generally for the axis 1 problem. So you will give the person who has a borderline personality and who is anxious and depressed medication for that. You can't really medicate a personality disorder per se. Okay? Okay. The mental status exam, I'm sure you, yes?
Question, as we move through the axes, so the categories, in order to have an axis 2 disorder, do you have to have an axis 1 so that they're progressive?
No. Now, in practice, probably most people with personality disorders will have something, but not necessarily. You can have a personality disorder who thinks they're in great shape, a very narcissistic person, no depression, no anxiety, no issues, just a problem for everyone else, right? So you can have it. Anybody else? Okay, the mental status exam, you don't see this on all the evaluations, but you do see it on a number of them. And this is what you look for. Appearance, obviously if the person is disheveled, that tells you something right, or if they're neat and have a suit on, tells you something different. Movement and behavior, you can tell if someone is hallucinating usually by looking at them and their movement and behavior. You can also tell some movement disorders. Affect is is basically their mood. Affect and mood are somewhat the same. Affect is the emotion that you show, so if the person is crying, it tells you something, right? Their mood, if they're hypomanic, we think someone has a manic parent in here. We'll talk about that, but you can tell that by looking at the person. Speech is good to look at for schizophrenia or for psychoses, as is thought content and thought process, which we'll look at a little bit. Cognition, you've probably heard of some of these little tests that they give. Count backwards by 3 from 100. Explain a proverb. This lets us know if you can think abstractly. If you can't, you could have a cognitive disorder, like a brain tumor, or you could have a psychotic disorder. Judgment and insight. Insight is whether you realize you have a problem or not. I'll just tell you a quick little story about this issue because I think it helps you not take this quite so seriously. There's a very famous study that's called On Being Sane in Insane Places. It's done, I think, about 20 years ago, where a psychologist was tired of all the overdiagnoses he was seeing. So he sent a number of his graduate students into the emergency room of several hospitals, and they said, I am hearing noises, they say thud. That was it. They all got admitted to the hospital as schizophrenics, but then they started acting normally, taking notes, saying, I really don't have a problem, I should be out of here, I'm really a student, and they couldn't get out. Every one of them was in there like, denies the problem, no insight, thinks he's a student. So the hospitals got very upset at this man, and he said, okay, I'll do it again. And so they were on their guard. The same thing happened again. So it is a problem in these terms. It's a very classic study, a very clever study. Yes?
I have a question. What does flat affect mean? We read that all the time.
Okay, flat affect means that you don't have any, basically. You're just kind of sitting there like this.
No emotion.
Right.
Okay.
Which would generally be depression. Yes?
Would that be similar to being catatonic or?
Catatonic is something that you don't see anymore. In my entire career, which was at the beginning of my career, I've seen one person. Catatonic person is generally someone who can stand like this for 3 days. It's unbelievable to see. Or doesn't move at all. Now, why we don't see that anymore, I don't know. It's interesting. We kind of use it in general parlance, like, oh, the person's catatonic, which means they're very depressed. But the official diagnosis is a type of schizophrenia, which you see rarely. Now, the flat affect is just that you're just sitting there, you don't have any feelings, really, that you're showing. Okay. Okay, next one.
Sorry.
Okay, I'm going to look first at the diagnoses of children and adolescents. Now, you'll see later, and also from your own reports, that many children are diagnosed with adult disorders. These are just the ones that are first diagnosed in infancy, childhood, or adolescence. And you can see the list of them. I've given you, so you'll have it for later, this is the entire classification, which is in this book. So you can see how it works. Here's the disorders first diagnosed in infancy. Begins with mental retardation, learning disorders, motor skills, communication, pervasive developmental disorders, ADD, feeding and eating disorders, tic disorders, elimination, and then other. Usually we have an other category. Reactive attachment disorder happens to be in that, because that's relatively new. So you can watch this for where we are in the diagnostic criteria. Okay, pervasive developmental disorders. This is a very interesting area, because when I started working, you either saw an autistic child or not. They were very obvious to look at. I remember in my training, I went into a state hospital, and there was a room maybe twice as big as this, and it had one of those old metal swing sets in it. There were autistic children on it, kind of swinging back and forth, little squeaks, not a sound from them. A lot of autistic children don't speak. This is obviously a very severe disorder. Does anyone have an autistic child in their caseload here? No. Nobody knows what causes it. There's been a lot of research into it. food additives. There's a big issue about the vaccines and what was in the infant vaccines. That does not seem to be accurate. But if you see an autistic child, you cannot mistake the diagnosis. They usually are very interested in parts of things, like a piece of string or used milk straws. They'll become very fixated on something. They don't want any change at all. If you try to change their routine, they'll usually scream. Right? They usually don't make eye contact. So it's a very severe illness. Usually comes on after a couple of years, although we do have some interesting videos of newborn twins where you can see one twin who becomes autistic. That twin will usually not make eye contact and will have an arched back and will not sort of mold into the mom. This used to be blamed on the mother. Bruno Bettelheim from the University of Chicago talked about the refrigerator mother. So you can imagine if you have an autistic child, which really is a biological problem, and it's blamed on you as a refrigerator mother. Very, very difficult situation. However, in the last 20 years or so, we've begun to see a spectrum of these disorders. So autism is called a spectrum disorder, which means it can be minor or major, and it also has Asperger's and the not otherwise specified classification, which a lot of children are put into. No one knows why this has happened, why there seem to be more, whether we're seeing them more, or whether something is happening in the environment that's increasing this. So a PDD child basically has extreme deficits in social interaction skills, and you can't miss this child. They basically cannot relate to other people. And autistic children tend to have very stereotyped interests. Asperger's kids will have a stereotyped interest, but it will not be one thing like a milk straw. It will be baseball statistics, something like this. Asperger's kids usually are not retarded, or probably always are not retarded, because that's why we diagnose them that. They don't have the language problems that autistic kids have. I remember a few years ago I had a 3-year-old come into my office. I have never seen anything like this. He did not stop talking. So he said every thought he had. I saw him for 2 hours, every single thought. He could not inhibit his talk. That's a really difficult problem, right? How are you going to deal with that? Basically by special education. Often autism and these disorders have mental retardation with them. And as I said, the incidence seems to be increasing. Go ahead, yes?
A question, when you look at children who are diagnosed as autistic, change is very upsetting generally. What's the color in that different type of stimulation? Why is that? Is that something visually that is a challenge for them?
Well, one of the ideas is that the brain cannot take human stimulation or other kinds of stimulation, which would explain why the eye contact is a problem. And it's interesting because you see, we have videos of some people treating autistic kids. It's really 24 hours a day, giving them food or candy to look at you. It's, to me, I think it's almost abusive. And so if one of the problems is that it's too stimulating to the brain to look at somebody, if you're forcing them to do it, it's not good, right? So it seems to be some issue of stimulation. So you could say that for that child, the color was too stimulating. Okay, anybody else? Okay. I have the diagnostic criteria are on your handout if you want to follow that this will be on page 75. This is the diagnostic criteria. It's too long to read, but you can look at this and follow these as we go along. Okay. Asperger's, I just talked about. Sometimes it is difficult because all autistic children are not retarded, so sometimes the diagnosis is difficult. We really don't know the prevalence of it, and it's definitely a lifelong disorder. The only answer we have at this point is special education. And you're basically training the brain in social skills. Look at me, talk to me. We're going to change this right now. Right now, we're leaving the room and we're going to lunch. giving you 10 minutes warning, get your stuff put away. You basically are training the child and hoping that it will take. Yes?
I often hear Asperger's associated with physical acting out, violence, and as they get older, become less controlled in their behaviors.
I don't think that's a general problem. It's interesting because a lot of people think that a lot of professors are Asperger's. That, there's a lot of people that, maybe this is more prevalent than we think. I mean, you certainly probably know people yourself who have very bad social skills, don't look you in the eye. People will say, oh, that's, they'll hide in physics, for example, or, science, where they don't have to relate to somebody. So whether that's overdiagnosed or not, there does seem to be a continuum. There's some people that just don't have good social skills, but they really don't have that kind of single interest that Asperger's people do. And I don't think as a rule they're violent. A lot of them go to college, and a lot of them get good jobs. Just that their social lives are difficult. Okay, anything else? Okay, talk to you a little bit about the treatment. Basically, you're targeting behaviors. You're not trying to control or trying to cure the disorder. You're trying to change the behavior so the child can have a social life in society. ADD, the criteria here is on 92 to 93. I think you probably don't have to look at that because I think probably everyone knows what it is, right? There are 3 types. Most kids have both that are diagnosed, which are the inattentive type and the hyperactive acting out type. The inattentive type has really been ignored for a long time. You see that more in girls because they're not a problem in class, but they're really not paying attention because their mind's all over the place. We're picking that up, I think, a lot better now and dealing with that better. Okay. As you, I'm sure, know, associated features, stubbornness, low frustration tolerance, temper problems, rejection by peers and family is one of the hardest problems for these kids because they're almost always rejected because they're so difficult to be around. There is a continuum of severity. I remember one time I was in my office and a mother brought in her older son, who was about 5, who had a fairly obvious ADD, pretty hyperactive. She forgot about the 14-month-old who ran around my office and actually had the screen open and was halfway out the window before we could catch him. That's how hyperactive that child is. I don't know what finally happened to this family because that is such a life-endangering problem. That's incredibly severe. There is a whole continuum of severity. One of the problems is this overdiagnosed? If a boy moves in class, does that make him an ADD kid? And another problem is that the teachers diagnose this a lot. Basically because we use checklists, we don't really know how to diagnose this. There's no blood test, there's no really great psychological test. There's a computer test that only looks at your attention, but you cannot be paying attention for a lot of reasons, right? So the teachers like to diagnose it, and these kids are a pain in school. So one issue is, did teachers used to beat this out of kids before? So they were too scared to do anything. Were they always there? Is this new? Again, something that we really don't know. The estimated prevalence is 3 to 7% of school-age children. That's quite high, right, for an issue like this. And in most cases, as you probably know, the symptoms attenuate. They're better by adulthood. Did you want to ask?
I did. I had a child that was diagnosed with ADD, the attentive.
Inattentive type.
Right. But then also could also be depressed. So it was almost like it was an either or thing. How would you
make the diagnosis?
See either one of those, and how would you know?
Because people who are depressed can't pay attention very well. But that should not be that hard a diagnosis to make because depression is diagnosed well by self-report. People don't like to be depressed. They'll tell you what they feel like, right? They'll answer your checklists. So it shouldn't be that hard to make. But one of the problems is inattentiveness is a problem with a number of diagnoses. Post-traumatic stress disorder. Anything that makes you anxious will make you inattentive, right? So it's, you have to kind of know the categories and really look at the particular person. Okay. Treatment is very controversial. We use these behavioral rating scales. You will see the psychological evaluation in your report of the child, where they'll do the IQ testing. Sometimes their IQs are lower than they, quote, should be, although IQ is really just what the IQ test measures, because we don't know how to measure real IQ. And we found that the behavioral and medication treatments are the best. You probably heard of these medications: Adderall, Concerta, Cylert, and Ritalin. A lot of people